That's a loaded question. So Regorafenib in gastric cancer still is in early phases of development. We're still not completely sure where it's going to end up fitting. It's a drug that certainly has a slight more toxicity, even to the point that in colorectal cancer, the redose trials and some of the different alternative dosing regimens have been up and coming and probably adopted by most of the people around the world. In gastric cancer, we're still holding into the previous arena, and we're actually awaiting the more confirmatory trials to see that Regorafenib indeed is going to be breaking the ceiling also in subsequent lines in gastric cancer. I have used Regorafenib in countless numbers of patients, and I always used to say that I always used to start at the standard package insert dose of 160 milligrams, but I would never finish at that dose. While now with the redose, we're seeing that we are finishing some patients at the full dose. So I don't know if what we're doing is we're selecting for the better performance status patients or for the patients that truly derive a benefit from Regorafenib, and that 30% that it was the tail of the curve that we used to see, and we always used to dream of those patients, of how do we differentiate those patients. Maybe the redose is kind of like weeding the patients that are not going to define a good prognosis in the beginning, not continue to expose them to higher doses, and then the ones that are truly benefiting from the drug, getting to the full doses later on.